Ceritinib was the second drug to be evaluated, and it looked like it was an effective drug when compared to chemotherapy. However, ceritinib has a lot of side effects that can emerge from the treatment of ceritinib, the most common of which are GI upset as well as liver function abnormalities. I personally have had patients take ceritinib. However, I have never been able to treat any patient at the prescribed dose that was prescribed or is currently FDA approved, just because I've always had to dose reduce because of liver function or GI issues. Having said that, ceritinib doesn't really have a clear place in the management of patients with ALK positive disease anymore, just because we have newer drugs, which I'll talk about in more detail. I've gone to 300 as the most, effective, but, the best tolerated that I could get. I have not gone below that. But my experience with ceritinib has been thankfully limited because now we have better drugs that are available. So that leaves us with 3 new drugs, so alectinib, brigatinib, and lorlatinib. So alectinib is, another newer generation ALK inhibitor, which was really, which came about to be our favored drug after results of a clinical trial where it was compared head-to-head against crizotinib in the first-line management of patients with lung cancer. And there were 2, it was global studies. The Japanese data were presented first, and then we saw the data that included North American population. And basically what we learned was that there was significant improvement in our ability to delay progression with the use of alectinib over crizotinib alone. We know that with crizotinib, we were able to stall the disease or delay the progression till about 9 to 11 months. However, with alectinib, the first time the data came around, the median progression-free survival was greater than 24 months. And at the most recent reports, it's about 35 months. So this is not even survival. This is our ability to delay the appearance of a new lesion. But what was more striking was that even in the absence of targeted radiation to the brain, alectinib in of itself was able to shrink tumors within the brain. And this level of blood-brain penetration we had not seen with crizotinib before, or even with ceritinib. It was much better tolerated. We did not see the same kind of visual issues. We did not see the same kind of GI issues. We did not see the same kind of LFT abnormalities. Based on all of these parameters of improvement in delaying progression, improvement in brain metastases, improvement in or delaying the appearance of new brain metastases, and overall better tolerability, we easily adopted alectinib as our new favored frontline therapy for patients with ALK-positive disease. When this FDA approval came about, I had a difficult decision, what to do with patients who had previously been placed on crizotinib. Do I go about changing everyone, or what to do with patients who had been previously on ceritinib? Now I have this new drug at my disposal. I know it's better, but what about patients who had been on crizotinib for 9 months, 18 months, 20 months? I mean, there are certainly patients who had been on crizotinib for a long time. And really, our strategy at that time was that if there was anyone who was really tolerating crizotinib or a first or second generation TKI well, at that time we would continue them on the same drug, because we know that these new drugs are also important for resistance mutations. So hold on to that thought, and I'll come back to the idea of introducing a new agent later on. But coming back to first-line therapy now, in 2019, if somebody comes into my clinic, I will be starting them on alectinib. However, I have another option now, which is brigatinib. So brigatinib is a newer generation ALK TKI, which was also compared head-to-head against crizotinib in a recent study. And we saw very similar data to to what we had seen with alectinib. So brigatinib becomes another option for first-line treatment in non-small cell lung cancer. Brigatinib is currently approved for the second-line treatment already after failure of crizotinib. And I will remind everyone that after failure of crizotinib, alectinib is also approved, and so is ceritinib. But brigatinib is another agent that has been approved in the second-line setting. And recently, first-line data looked as promising. You can't really compare trials to trials, but if we were to do so, it looks, nearly as good as alectinib does. So I talked to you about our favored approach. I think brigatinib is a reasonable option. One specific thing about brigatinib is that it sets it apart is that there is a specific component of pulmonary toxicity that can occur with brigatinib. And what do I mean by that? I mean that there are some patients that can develop lung infiltrates or shortness of breath with the use of brigatinib. And in fact, the dosing of brigatinib has been modified and tailored through the use of clinical trials in such an approach that we start off at a slightly lower dose and then dose escalate up to the 180 that's prescribed with brigatinib. So those are some very specific sort of side effects with brigatinib, but overall otherwise seems very well tolerated.
The lung toxicities, is it a sort of a tolerance, or you're weeding out the people that have the problem?
I don't think we clearly know at this point in time, but it seems like if you take a stepped up approach, that you can minimize the risk of pulmonary toxicity from appearing. For the same person. But there is, a lot of activity in doing research around this drug in terms of what really is the mechanism. And in fact, a study at University of Colorado is looking at pre and post pulmonary function to see what really is going on. So a lot of research going on in that area. Yes?
I wanted you to talk about lorlatinib in ALK mutation.
Yes, so
there's been some very good data recently.
Absolutely. So that's the next topic I was coming to. So thank you for cueing me for that. So lorlatinib is our latest drug on the block, and actually is now FDA approved after failure of therapy in the second, third line setting. So it's a really good, invaluable tool to have, and also we are blessed to have the FDA approval to be able to use it. Where do we use lorlatinib? So lorlatinib is the newest kid on the block. We use it if there's somebody who's been on alectinib or brigatinib or even ceritinib and crizotinib and has failed their treatment. There is a lot of interest in really defining which patients will benefit from lorlatinib versus which patients, after they have been on a first or second generation TKI, will benefit from alectinib or brigatinib. Sorry.
I wanted to talk about the brain and lorlatinib. It's extremely effective in getting into the brain, preventing future lesions if you've had lesions in the past. In 3.5 years, I've had no increase in lesions. I just have a tiny one that's never changed in shape or size. No new lesions for 3.5 years.
Mm-hmm.
So it definitely gets into the brain.
Yeah.
There's a lot of brain side effects, though, for a lot of people. There are the 54% cognitive side effects.
Yeah. So I think that's a so those are two very important points that have been brought up. So the first point was the brain penetration with these newer drugs, especially lorlatinib, and the second one was the side effect profile of these drugs. So I'll touch upon both of those. Yeah, go ahead.
Right, to continue with what she was saying, the memory issues are like 0 to 10 or 20 seconds. That's kind of the parameter of just enough time to put your keys down somewhere and never be able to remember where you put them, which is something we all do now and then. But with lorlatinib, it's a constant. You're constantly battling that extreme short-term memory problem.
That's actually a very good perspective to have, because as you may be aware, we don't have a lot of patients currently on lorlatinib. We are blessed that patients who started alectinib have been able to remain on that for a while, but there's a very few select group of patients who are currently on lorlatinib, so having this perspective is very helpful. But what sets lorlatinib apart is this activity in patients who have had mutations, especially after the use of a first generation TKI, meaning crizotinib. So lorlatinib does have significant brain penetration, where without the use of a radiation modality, be it SRS or whole brain, we are able to see shrinkage of these brain lesions in a very similar fashion that we saw with alectinib. But these are patients that have even previously failed alectinib and now are responding to lorlatinib. So it really gives us the opportunity to be able to add yet another ALK agent at the back end. So I did have one patient where I jumped from alectinib to lorlatinib, and then did not have, unfortunately, a significant response. And actually, we could not find a mutation either by tissue or by blood to be able to specifically direct therapy. And as sort of like a last-ditch effort, we tried brigatinib because brigatinib was approved by that time. And unfortunately, we did not see a response. So I think there's a lot that we have to learn about sequencing therapies. We're getting some signals from the most recent publication from Dr. Shaw about resistance mutations and how they may impact our choice of subsequent therapy. But I think this issue is very real of where do you go next? I don't think we have an answer.
I can just say I went from alectinib to brigatinib. It's working fantastic.
Great.
That's great.
But did you have resistance on alectinib?
I had growth on alectinib.
But did they detect an actual mutation, or was that?
I had an additional mutation, but not one of the famous ones.
Okay.
It was an obscure one.
Okay. On liquid biopsy or on tissue? Just curious. On tissue. Okay.
You segued into a point that I don't know most patients know. There's an ALK master protocol trial that just opened like in the last week that seeks to find out this exact issue, like when you go on a second generation ALK inhibitor like alectinib, what's next, what's proper. So anyone who's an ALK patient in here, it's a clinical trial, but not one that like it's hard to get into in the same way, right? So it's something that we all should consider doing to really learn about what's next, because it includes all possible drugs and beyond, right?
So I will just echo that that's a national effort, and that's a trial that's sponsored and funded and supported by the NCI. So there's a lot of effort. It's multi-institutional, it's collaborative, and really the goal of that is to really just understand what we talked about, how to sequence therapies, how can we really look at resistance mutations, which therapy to go to next. And there's a lot of very good investigators that are putting their time and effort in developing these drugs and developing this protocol. There is another protocol that is being sponsored by the Bonnie-Dario Lung Cancer Foundation. It's called ALKME, where basically they're looking at the use of liquid biopsies as a tool to really detect mutations. It's sponsored by the Dario Lung Cancer Medical Institute. So I think that's something else that's out there that you should be aware of, that's available and a resource to patients.
And it's called spacewalk.
Yeah.
But
Just so we're all on the same page.
yeah.
Which anybody,
Yeah.
once you progress, you have to progress
Yeah.
first before you qualify.
Right, for both of those. we need
For
to
both, you have to
progress.
progress first.
Right. How about the issue, so I actually have, besides ALK, a MET amplification, and that actually has been there upon diagnosis. And I note that the role of MET evolving, and it's been evolving in EGFR, but it seems like it's sort of evolving in ALK as well. Can you talk about that, the use of combination therapies?
Yeah, so, MET, there is some activity that crizotinib has against MET, has against ROS1 also. There is potentially a role of combining therapies, nothing that's widely used if there's already a pre-existing MET amplification that travels along with the ALK rearrangement. I have not seen any reported recent case reports on combination therapies that have been successful. I know of emergent MET amplifications that have come on while patients are on ALK therapies, but not something that's been pre-existing and sort of travels along. A word of caution about things that are pre-existing and things that emerge, they may be passenger mutations versus driver mutations, meaning that there may be a mutation that pre-exists and just travels along with the actual mutation, which we call as a passenger. There, or it may be a slightly, a MET amplification may not necessarily be a driver. Sure, I was talking about, let's say, a MET amplification, which is not really a MET exon 14 skipping mutation, for example, and MET amplification may just be a passenger that's driving along and or is passengering along and is not really driving the tumor.
If it was a test that actually said if it was an oncogene driver.
But that's something that emerges.
No, I'm saying, like, let's say you did like the MSK impact. and
Sure.
They tell you something is an oncogene driver or not.
Yeah.
Is what you're describing would not be an oncogene
It-
driver,
it-
or it could be?
It would
I'm
independently.
asking her. What?
So what I'm describing as a passenger usually is not in the driver's seat, is not really driving the tumor. It would not be identified as a driver necessarily for that disease. For example, there may be mutations that have known to be oncogenic in other tumors, but we are finding it in lung cancer. And so it may be, so there are some nuances to that.
So it's not yet clear entirely.
Exactly. So it may be oncogenic in another cancer, but not necessarily.
It's oncogenic in lung cancer.
So MET amplification has been shown to be related to lung cancer, but I'm not sure if MET amplification alone is enough to be a driver, as much as MET exon 14 skipping mutation.
Could it be considered a translocation or a fusion?
No, that would be a completely different sort of mechanism of the way the gene is being mutated, so to speak. Melina, you have something to add?
So I think that one thing about the reports is that, they look at those mutations individually, and so they call them an oncogene just because it's in their database as an oncogene, but they're not saying that it's a driver in the context of the other mutations that are on the report. So it's just purely their specification that's spitting it out. And then the other thing, which Charu can maybe talk a little bit more about, is that amplification on a DNA test is very difficult to interpret. So for instance, liquid biopsies overcall amplifications all the time, and a DNA amplification may not translate actually to a protein that's amplified. So it's a difference in terms of how it's functional.
Amplification is?
So amplification is basically excess copy numbers of the gene that we are talking about. So it's, having 3 instead of 1 or having 8 instead of 1, that's really what amplification is. It doesn't really mean that that particular gene is mutated or deleted or translocated or inverted or fused in any way. It just means that there are more copy numbers of it is what we classify as amplification.
And its role isn't yet known, or it is for certain?
So it's a very hot topic for research in lung cancer because we know in EGFR mutant lung cancer, MET can be amplified at the time of resistance. But MET in itself can also be mutated, what we call as the MET exon 14 skipping mutation, which becomes sort of like its completely different subset. So I think to your question of, would you do something about MET in terms of an additional therapy? I don't think we have a clear answer. There have been case reports of an emergent RET fusion in patients who've been on ALK therapy, and they have benefited from combination. Or there have been emergent cases of ALK on patients who have had EGFR. So very interesting things that we're finding where therapies have been combined. I just don't have a clear answer for the MET story just yet. Go ahead.
What do you want to see as improvement to the blood biopsy option? What would you like to see in terms of reliability and detect what it detects?
Yeah. So that's a very good question. So, there is a certain threshold where the test reports result out a particular mutation. And it's different for each test. It basically draws a line in the sand and says, if your circulating DNA is above a certain threshold, we will report it on the clinical report. However, there are patients who have slightly lower circulating DNA than that threshold that they've set. What I would like to see is that we lower those thresholds and make the tests even more sensitive so that even if there's a very few copies of DNA circulating in the bloodstream, that we are still able to report on them. They're able to detect them. The levels of detection are very low now with these new technologies, but the level of detection and the reporting level, there's a large gap. So when we read a negative report, it doesn't mean that there's no circulating DNA. It just means that it may have been floating at a much lower level than the test company feels comfortable reporting out. So what I would like to really see in the future is the levels of reporting go down as our tools become more sensitive.
Can I just ask, what is the likelihood that a very non-tested mutation, for example, when I had a progression, I had this new rarer but oncogenically defined mutation. I only have like 2 or 3 ever reported, so I've heard of mutations, ALK being one of them. And apparently I had that, they did a manual look back and said, we see you had a little bit of this in the very beginning, but it wasn't reported. And now, there's more of it. And I just want to confirm, you're saying it could just be still a passenger mutation. So I'm wondering if it's also possible, because my details of my cancer are sort of very rare, whether I could have some mutation that's not on their panel of 500 genes.
And it could very well be the case that the mutation is there. It's not something that we have seen enough of or know much about. For example, even the G1202R mutation, that's now, the most common mutation we look for and have the most experience with. We didn't know anything about that 5 years ago, right? So it may be just that we just don't have enough information or enough trials, and that's.
It's not being tested for, or that it's not being reported on their list?
I think both. As the panels become larger, our ability to be able to sequence that particular spot in that gene, the ability becomes better, but also that when these reports come in, then we can actually pool our data together and actually see what happens to that particular mutation. So I think it's a little bit of both, and our improvement is improving, but also to stress that the liquid biopsy panels may not be large enough to be able to get those, so tissue biopsy may be extremely important in these cases, especially in ALK.
So, you made, a lot of the outcomes we saw are fairly recent, publication by Cambridge et al. Saying that the median survival rate for their cohort of ALK patients was 6.8 years. And they attributed it to, in part, the use of chemotherapy, particularly Ellipta. I won't use the generic name, I'll trip up on it. Can you talk about the role of chemotherapy in the mix?
Sure. So I'll answer this and I'll come to your question. So as we have these 5 drugs now, I think our use of chemotherapy has decreased significantly, at least in the upfront management of these patients. However, I do think that chemotherapy has a much much more defined role than immunotherapy does. Drugs like Alimta or pemetrexed specifically have been shown to have very good efficacy in patients who have had ALK-related lung cancer. For my patient experience that I discussed with you, where lorlatinib didn't work and brigatinib didn't work, actually Alimta was the drug that worked after that. The reason why we didn't choose Alimta first was we were trying to really avoid using an IV systemic treatment when we could use a pill, which was going to be presumably slightly better tolerated. But having had patients who receive Alimta all the time because of the lack of a mutation, I can say that Alimta is also very well tolerated compared to some of the taxanes. And it definitely has a role, I would say, much later lines of therapy, not so much upfront. Would you agree, Melina?
Yeah, I mean, it's the same in ROS1 too, just to, that there's some, good
Similarities.
efficacy with pemetrexed and ROS1.
Do you think if you have a squamous or adenosquamous ALK, which now they're thinking is probably from a precursor before it differentiated the histology, that pemetrexed would work, or it just wouldn't against the squamous?
So I think it's worthwhile trying the pemetrexed because squam may be a component of the tumor or maybe just one specific area.
50-50 or more.
I think you would still,
I mean, why doesn't it work for the squamous, and could it work for the squamous ALK, or what is the idea behind it?
so it has to do with an enzyme called thymidylate synthase. Thymidylate synthase is basically an enzyme that is very, very high in squamous tumors, and it basically inhibits the use of, efficacy of Alimta. And that's the reason why it doesn't work in small cell, it doesn't work in squamous. I mean, it has been tested in squamous, it just doesn't, it works, but it doesn't work as well.
So the ALK is just like a side thing, the histology is actually more important, you think?
I think so, yes. I don't want to forget about your question.
Okay, I just wanted, if you could just discuss about dosing and when, just in general, just like, there's studies all over the place on this, on, reducing doses, increasing, going over the standard dose. And I understand when there's progression, you want to squeeze as much as you can out of your current TKI, so often increased dose is the way to go. What are the thoughts for no progression or things on dosing in general?
I think that's an excellent question. Our traditional standard of care approach usually is to start with the FDA-approved dose and then dose reduce in case of toxicity. Thankfully for alectinib or brigatinib, we haven't been, for brigatinib, we usually go up to the FDA-approved dose. However, for let's say alectinib, we have not really needed to reduce the dose, which is distinct from ceritinib. You're on reduced dose, okay. Because of fatigue or liver? Okay. So I have had one patient where I've had to reduce the dose for alectinib, and that was for really horrible fatigue. The patient just could not function at the prescribed dose and is now on 150. And I think
150
twice a day.
So 300 a day.
Yeah.
Okay.
Yeah. And, the real driver in that case was fatigue, but for the most part, we were able to get by with the prescribed dose of alectinib, which is not the same for ceritinib, for example, where we always had to dose reduce. And then we usually go back to what has been the experience on the phase 1 trial. All these drugs were tested in phase 1 trial, and where patients were dosed on an escalated pattern. And really, my justification for dose reducing ceritinib, for example, had been that there were responses seen even at 150, 300, 450, 750, on that trial, there were responses seen at each dose level. It wasn't that the responses weren't seen. It's just that they found that the maximum tolerated dose or the maximum threshold that they could reach with that drug was a particular level, which then they decided to take into phase 2.
So is the thinking that, and I know I just want to talk about it, I guess, or think about it, is if a minimum dose mechanisms of resistance appear faster?
So
because
not
it's low,
necessarily.
Or is more better?
Yeah.
What is it like?
So more is not necessarily better in terms of targeted therapies. We certainly have EGFR patients who are on, who used to be on doses as low as 50 milligrams of Tarceva when the actual dose was 150, and they were able to tolerate it beautifully, but also have the same efficacy as you would expect with 150. So I would say that with targeted therapies is more of a function of what is the minimum dose that's required to inhibit the receptor engagement at that point. I don't know, Melina, if you want to add something to that.
And then, go ahead.
No, please, ask yourself.
No, and then if there's progression, go ahead, please.
I'm gonna use.
Yeah. Come here.
So I think one thing to keep in mind is kind of how they find these doses, and Dr. Aggarwal was talking about that a little bit, but in the phase 1 trial, they basically dose escalate until the point that the side effects are too high, and then they usually kind of go down just a little bit, and then they test that dose for efficacy. And so it's not as though they picked the most effective dose, they picked the dose that was just barely tolerated. And so it's an unfortunate reality of drug development. But and then the other thing was with these TKIs, everybody has different enzymes. Everybody has different, amount of disease. And so the dose for you is not the dose, for another patient. And we're learning that, I think, slowly. And I think being more liberal about dose reducing, knowing now that there's not usually a drop in efficacy. And they've looked at this for some of the more toxic TKIs. So when we're not in the EGFR room, but afatinib in particular was harder to tolerate. And so they looked at actually the half dose and saw that patients did just as well if they were on half the dose. So it's not part of the label, so you can't, really say that you can start at half the dose. But, in the real world, people on that lower dose actually do just fine.
When you say amount of disease, are you saying that if you have 4 tumors, you probably need more of most of these drugs than if you have one small one?
I say that. I actually don't think there's good evidence to prove that, but that's just kind of a gestalt that we use. But I don't actually think there's good data to say that that's actually true. Yeah.
Could you be in the targeted therapy and all of a sudden you're tolerating it and everything, and all of a sudden things like that become toxic or not tolerated? Is that possible?
Yeah, that's a great question. So generally, we do see the most toxicity at the beginning. Usually we say the first 6 weeks, but toxicity can ebb and flow. And so it's not impossible that a year down the road, a rash could pop up or things like that can happen, certainly. But generally we see the most toxicity in the beginning.
You had a question?
Yeah.
Yeah, so how does the calculus change when you have CNS involvement, if at all, for you guys?
Yeah. So the question is, how does the calculus change when we have CNS involvement? I think a lot has to do with the extent of CNS involvement, the size, and the symptoms. So those are the 3 things that we look at. If they're very, very small foci that we are seeing on a brain MRI, and the patient is completely asymptomatic, and I'm anyway changing therapy to a more potent blood penetrant drug, I'm more likely to say, let me switch the patient to alectinib or lorlatinib at this time and not do anything about the brain. So asymptomatic small lesions, I'm more comfortable with just using the TKI that has better blood-brain penetration as my line of attack. However, if there is a bigger mass, or if there's a mass that's causing a shift or symptoms, or potentially a mass that can compromise functionality or motor function, then we certainly bring in both our neurosurgical colleagues as well as radiation oncology colleagues to consider local therapy, be it surgical resection or the use of stereotactic radiation therapy or gamma knife to control that, in addition to using a blood penetrant drug. So I don't think there's a clean-cut answer. I think it has to do with size, location, and symptoms.
But how about dosing as well? There is some published evidence to increase the dose versus an alectinib, and that's effective once there's some progression on alectinib in stabilizing or reducing brain mets.
So you're really asking about the dosing question with these drugs in the presence of new brain metastases, and I think this phenomenon of increasing dose is much more prevalent in EGFR mutant disease, where with the older drugs we were able to use something called as a pulse dose phenomenon or pulse dose technique, where we would take a higher dose of Tarceva. So instead of giving a daily dose of 150, we would say let's just take 1500 once a week, and that would potentially increase blood-brain penetration. There have been a few case reports of using this with ALK-directed therapies as well, something that we don't commonly use at this point in time, just because if this is happening on a first generation TKI, we usually go to alectinib or lorlatinib, or if it's happening with alectinib, we think about going to lorlatinib at that point in time. So I haven't personally dose escalated just for brain disease yet.
I'm on it.
Okay.
That's why I'm asking.
So how much dose are you on now?
1,800 a day.
And how's that working out in terms of tolerability and?
Fine. No, it's fine. My side effects are not noticeably different.
That's great.
Can I ask two questions related to that? For most of the drugs, if you did a pulsing along the lines of what you said, instead of 150, 1500, 10 times as much, for the ALK drugs, would the toxicity be more concern? And also, separate question for the neurosurgical, if you develop, you haven't had brain metastases yet, develop brain metastases, the concern, would they operate? Because I know a lot of times, there was this idea that, then you'll just get other stuff, it's not worth our doing this. Has that thought changed, or it depends on the surgeon, or what is it?
So in terms of your first question about tolerability of these ALK agents, I think, there's a member in the audience who attests that, this seems like a safe and well-tolerated approach. I think the thresholds of the increase will be different for different drugs. Yeah, so the thresholds will be different, and I don't think at this point I feel comfortable just going to 10 times of a dose without really having some kind of evidence behind it. The reason why we were able to use the 1500 milligram dose for Tarceva was because of published, peer-reviewed and vetted experience with that dose, and that's how it became a little more universal in terms of its applicability. But I will remind you that that use has gone away with the use of osimertinib. But there is some evidence that even increasing the dose of osimertinib may help with brain metastases. So instead of going 80, you go 160. So it's not really 10 times, it's sort of like doubling the dose. Again, the Tarceva pulse is 1500. It sounds like it's a 10 times, but it's a once a week. So, instead of 750, you're going to 1500.
The analogy with alectinib, then would instead of you doing 1800
Right.
a day, you would do 9,000 once a week. Do you think there's a lot of benefit or the toxicity?
I think we're talking in completely data-free zone. And then the second point of the question was really about surgical resectability for these, one or two brain metastases that may pop up. And I think our neurosurgeons are becoming much and much more comfortable. I feel that especially for the targeted therapy group, and with better drugs, if there is one symptomatic area, they're more likely to be aggressive about either removing it. And if they're not, then we do have other modalities like radiation therapy or gamma knife which can attack it. But I don't think we think about it like we're not going to treat it because there are other things that are going to come up.
Is one or the other easier to tolerate, the brain surgery or the radiation?
It really depends on the location and what the operability is at that point in time. I think it's a discussion to be had in a multidisciplinary fashion. Really, there are definitely real surgical morbidity that can happen with neurosurgery, but there's also some memory issues and cognitive issues, as well as the side effect of potential radionecrosis with radiation. So, I think it's sort of like a discussion that needs to be had really in a true multidisciplinary fashion. And I think there was a question there in the back.
Yeah, well, again, it's sort of going into what some others have mentioned. This whole sequencing of the drugs and the timing on drugs. I know, for example, if you've been on another TKI and then go to another one, it doesn't appear that you get as long out of it as you would if it was the first line treatment. Like, if you go to lorlatinib first versus being sick, I'm throwing it out there, lectinib first and then going to lorlatinib. So I'm always struggling in my own mind, and I don't know if there's no hard and fast answer. Are you better to squeeze as much out of each one by increasing dose or doing what they call weeding the garden? If you have a few metastases, you just take care of them through radiation or something. Stay on it for as long as possible while it's still working overall, and then moving on versus just moving on. And with that, and I think that we all feel this, as I look right now at lorlatinib as the end of the line, and to put that off as long as possible. Because I see it as the end of the line right now. Of course, there's chemo, but I'm just saying,
So, do you want to answer that? So I would just, I'll let Melina follow up on this. I would just say that, what is a much better established practice is, and what's currently endorsed by the NCCN is, in case of oligoprogression, meaning oligoprogression is basically oligo being few or limited and progression being progression. But if there's a few limited sites of progression, let's say you're overall doing great, but there's one tiny ditzel that shows up in the lung or one tiny ditzel that shows up in the brain, what is a much better scientifically proven approach, and that's included in the guidelines, is to radiate that area of oligoprogression and continue with the therapy than to go on and increase the therapy. So I completely hear you, and we agree as physicians and providers that we want to get as much benefit as we want from one particular therapy. So if you're on alectinib, I want to be able to get as much bang for the buck as I want. And if you were to open the NCCN guidelines, in fact, they say that there's one or two sites of disease, consider radiation and continuing therapy. I don't think we have a lot of data in terms of increasing dose that can be scientifically translated into guidelines just yet. I do think, and I certainly have patients who develop brain metastases on alectinib, and I have spot radiated or done gamma knife and be able to continue the alectinib without really increasing the dose. So I do understand the idea of increasing the dose, but just not guideline based right now.
Can you just briefly address if the tumor is in the chest area? So radiation, as I understand it, would be very trying there. You'd have a burning probably in your throat, pain on swallowing, lasts typically a month. You swallow many times a day, not only when you eat. You get fatigue. A decent percentage of people, it really decreases your quality of life. A 20% risk of radiation pneumonitis, which is coughing and whatnot for the rest of your life. So it's something I would want to avoid. Do you have thoughts, in other words, different from, say, if it was in your liver or somewhere else? Is there a general thought that's taking into account quality of life and saying, look, for an area like that, maybe you won't act the same way as you would if it was oligo somewhere else?
Yeah, no, I think definitely. I mean, I think you're talking about a pretty central lesion, so maybe like a lymph node in the middle of the chest that would be really close to the esophagus or something and would cause some of those. And the radiation oncologist should be able to go through the risks and the benefits of certain, locations with you.
So that's what I'm saying, this generalized concept of in oligoprogression, go to radiation, you would agree that it doesn't necessarily apply in the same force if it was somewhere like that has more quality of
We would still consider it. We definitely would, and it's all about risks and benefits. Yeah. So, if you were really worried about the esophagitis or the risk of, radiation pneumonitis, it would be it could be.
So it's a reasonable personal.
It's certainly reasonable if the radiation oncologist feels that it's safe and technically feasible, then radiation to one or two areas that's growing is certainly an option and is something to consider.
And proton therapy may be able to reduce some of the overlap with, the vital organs. If it's a very central lesion, they have better stopping so that they are not affecting the heart or the esophagus. So I think there are ways to mitigate that risk of esophagitis or swelling of the esophagus or the lungs. So again, I think it's still in the running for oligoprogressive radiation therapy being an option.
How about Insartinib? We don't talk a lot about that, but that's a clinical trial, has some published efficacy against ALK. I mean, I've even heard it can sometimes work against elective refractory disease. So have you heard anything to share?
So no personal experience to share, but again, I think it's one of the drugs which is, again, in the running for what will we do next after alectinib or lorlatinib. I don't have personal experience with the drug.
Or XDCM?
All right, we are almost up on time. Thank you so much for a delightful, engaging, interactive discussion. We will be around if you have more questions, and thank you so much for spending your Saturday morning with us. Thank you.